Hello guys, welcome to my channel. So this is Dr. Mithun. I'm doing super specialty in critical care. So this is another day. This is another day of discussion on our toxicology part. So today we will discuss about methanol poisoning and ethanol poisoning also. So without wasting much time, we'll go to the topic. So methanol, also known as wood alcohol, because it was first distilled from the wood, is a common ingredient in shellac, varnish, windshield washer fluid, and solid cooking fuel. So this is the picture about methanol poisoning, and this picture will give you a whole idea about the methanol metabolism and the issues, complications caused by methanol poisoning, and also the treatment options available. So methanol is first converted into formaldehyde by alcohol dehydrogenase. That is the first step. Then formaldehyde is converted into formic acid by aldehyde dehydrogenase. Then formic acid is converted into carbon dioxide and water. They are the metabolites. So methanol is an unmeasured osmol, so you can get an increased osmolar gap in this poisoning, and because of formic acid, uh, they can be decreased bicarbonate, and anion gap metabolic acidosis can be seen. And also this formic acid inhibits cytochrome C oxidase, and it can cause retinal and optic nerve damage. So about the about the treatment options available, so methanol and formic acid both are removed by hemodialysis, and fomepizole can be used as an antidote, uh, which inhibits alcohol dehydrogenase. And folate supplementation can also be given for the conversion of formic acid to carbon dioxide and water. So we'll go to the early manifestations, clinical manifestations because of methanol poisoning. So early manifestations can be seen within 6 hours of ingestion, and it includes signs of apparent inebriation without the odor of alcohol on the breath. Yeah, so it's the same as ethylene glycol intoxication. There will not be any odor of alcohol on the breath. Later signs 6 to 24 hours after ingestion include all the visual disturbances like scotoma, blurred vision, complete blindness can be there. Depressed consciousness, coma, and seizures can also present. Examination of retina can reveal papilledema and generalized retinal edema also. Visual disturbances are characteristic of methanol poisoning and are not a feature of ethylene glycol poisoning. So this is the feature which can differentiate by which we can differentiate between methanol and ethylene glycol poisoning. So when we come to the lab investigations, the laboratory studies show a high anion gap metabolic acidosis and elevated osmolar gap, as I told you. Then plasma assay for methanol is available, and a level above 20 mg per dl is considered toxic. Treatment of methanol poisoning is the same as described for ethylene glycol poisoning. We have discussed about the treatment options in the first picture only. So except for the following. Visual impairment is an indication for dialysis in methanol poisoning, whereas in ethylene glycol poisoning, uh, any signs of organ injury or severe acidosis like renal failure, pulmonary insufficiency, uh, like pulmonary edema or the pH less than 7.1, they are the indications of dialysis in ethylene glycol poisoning. So in methanol, visual impairment is an indication for dialysis. And folinic acid is used as adjunctive therapy in methanol poisoning instead of thiamine and pyridoxine, which are used in ethylene glycol poisoning. So folinic acid can convert formic acid to non-toxic metabolites. The recommended dose is 1 mg per kg IV up to 50 mg at 4-hour intervals. Folic acid should be used if folinic acid is not available. So that's it about methanol poisoning. So we'll come to ethanol metabolism. Ethanol poisoning. So ethanol is converted into acetaldehyde by alcohol dehydrogenase, and acetaldehyde is converted into acetate by acetaldehyde dehydrogenase. So the first step happens in the cytosol, and the second one in the mitochondria. So again, fomepizole inhibits alcohol dehydrogenase and inhibits the first step of ethanol metabolism. So this is the picture about acute alcohol intoxication. You can see the clinical features like euphoria, dysphoria. As you all know, the clinical features of acute alcohol intoxication. Disinhibition can be there, excitement, confusion, stupor, coma and death in like very severe intoxications. Complications can happen like alcoholic hepatitis, alcohol withdrawal syndrome, alcohol use disorder. That happens over that happens when the patient when the subject takes alcohol for a long period of time, not immediately. Um, so our initial management will be like Uh, we will go for airway stabilization and ventilatory support when the patient comes with acute alcohol intoxication. That is our first preference. We'll go for ABC management, airway, breathing, circulation. If the BP is low, we'll go for fluid challenge. Uh, we'll go for vasopressors if the BP is still low. Yeah. Then clinical effects of serum ethanol concentration. So if it is from 20 to 50 milligram per dl, there can be diminished fine motor coordination. If it is between 50 to 100 milligram per dl, there can be impaired judgment, impaired coordination. Between 100 to 150 milligram per dl, there can be difficulty with gait and balance. 150 to 250 milligram per dl, there can be lethargy, difficulty sitting upright without assistance. 300 milligram per dl can come with coma in the non-habituated drinker. 400 milligram per dl, there can be respiratory depression too. So when the patient comes, as I told you before, respiratory status first, including airway and breathing. If the patient is unable to protect their airway or has inadequate oxygenation or ventilation, tracheal intubation and mechanical ventilation are required. Effects may be more prominent when the concentrations are rising, when the alcohol concentrations are rising. That is called Melan-by effect. We'll discuss about that later. So IV hydration with isotonic crystalloid is given. Then comatose patients should receive parenteral thiamine to prevent or treat Wernicke's encephalopathy. This is a very important point in alcohol poisoning. In severe intoxication, activated charcoal and gastric lavage are generally not helpful because of the rapid rate of absorption of ethanol from the gastrointestinal tract. So this is Melan-by effect. There are two individuals. The first individual is drinking alcohol. He is getting intoxicated, getting more and more intoxicated. The second individual has stopped drinking, but the alcohol concentrations in both individuals are same. Still, the patient who is the patient who is drinking the patient who is drinking more uh, is more intoxicated than the patient who has stopped drinking. So the Melan-by effect explains how an individual appears clinically more inebriated while getting drunk than at the same blood concentration while sobering up. So this is the thing about driving. We are not good at recognizing what we are experiencing on an absolute scale, and that is a problem. So the patient who is more intoxicated, patient who is drinking more intoxicated, they can tell you like he can drive a car with ease. So you can't trust him because he's getting intoxicated. So this is about Wernicke's encephalopathy. Uh, Basically, thiamine it causes the caused by thiamine deficiency, seen in chronic alcoholics mainly. So other causes can be persistent vomiting, stomach cancer, etc. So this is a triad of Wernicke's encephalopathy. Confusion can be there, ataxia can be there. In ataxia, like patient can come with uncoordinated gait, unsteadiness can be there. Skint can also be there with nystagmus and ophthalmoplegia. So treatment is urgent IV thiamine injection even before glucose replacement. So what happens if we give glucose before thiamine? Like imagine a patient who is intoxicated with alcohol comes to the ER with hypoglycemia. So we have to give urgent IV thiamine injection before glucose replacement because the thiamine is a coenzyme in the glucose metabolism. So if we give glucose first, there will be increased demand of thiamine and it can actually worsen the situation. So urgent IV thiamine should be given even before glucose replacement. If not treated, can develop to Wernicke-Korsakoff syndrome. It can present with all the symptoms of all the signs of Wernicke's encephalopathy like confusion, ataxia, squint, and also retrograde amnesia and confabulation. So this is all about today. So this is a very concise video about ethanol and methanol poisoning. Hope you have enjoyed it. Hope you have got some knowledge about ethanol and methanol poisoning. Uh, so this is done for today, and we'll come up with a new video. We'll come up with a new toxicology session about something very interesting. So please subscribe to my channel. Thank you so much.